Maryland. I think you need over 60% vote, which means the Democrats might be able to preserve pieces of the Affordable Care Act, including the Innovation Center. Maryland's also just applied to extend the pilot from its first 5 years, which would take it through 2018, to another 5 years. And I'm sure the hope is that somehow that can be extended before Congressman Price becomes the head of Health and Human Services, and perhaps that could extend things for the next 5 years. But at the moment, things are really quite up in the air, and the consequences for Maryland hospitals, people employed at Maryland hospitals, and people getting care at Maryland hospitals is really quite dire.
Are the hospitals doing anything proactively in the event that this funding goes away and that they might have to close?
I'm sure collectively the hospitals are working to get the pilot extended before there is, the change of administration. Congressman Price is on record as saying he doesn't like the Innovation Center. So I'm sure they're working hard to extend it, and I'm sure every hospital is scratching its head and imagining what would they do if 2 years from now, imagining the pilot goes away and all of a sudden Medicare starts paying them 10 or 12% less, Medicaid starts paying them less, they have to raise their prices to commercial folks, and could they possibly survive? And so I'm sure people are planning. I don't know if they're planning collectively. I'm sure they'll be lobbying Senator Cardin collectively to try to preserve the Innovation Center and the pilot.
Peter, Republicans say that the fact insurers have been retreating from the state health insurance exchanges, and that those who are staying are requesting large premium increases is a sign that Obamacare is failing. Are they correct in their assessment?
I don't think so. I think you need to very quickly look at what comprises the Affordable Care Act, which is about 900 pages long, but you can boil it down to 3 general areas: insurance reform, getting rid of pre-existing condition exclusions, lifetime caps, rescissions, those types of things. Virtually everybody agrees that's a good thing. Even the Republicans generally agree with that. Second is increasing access, which has been done through expanding Medicaid, through the subsidies on the exchanges, and through allowing kids to stay on their parents' plans to 26. The latter is pretty well supported by most people. The 2 former, not so much, but both of those areas, in terms of insurance reform and increasing access, have really been a success, with 22 million additional people covered, to the point where now only 9% of Americans are uninsured instead of 16%. Where the Affordable Care Act did fall short, however, I think, is in what's called bending the cost curve. No one's ever said that you're going to decrease healthcare costs, but slowing down the increase is crucial. And in order to do so, you have to do 2 things. You have to change the mechanism by which healthcare is funded away from fee-for-service and towards capitation, and we have to focus on evidence-based medicine rather than just medicine that's done because what the docs or the patients really want to do without a lot of evidence backing it. Now, medicine is an art as well as a science, but there's plenty of science behind that, and unless we do those 2 things, we're not going to bend the cost curve. So I'd say in general, the Affordable Care Act has been a success, but there are clearly things that need to be addressed, and unfortunately, because elections have consequences, there's not going to be the bipartisan effort that could potentially have been available had the Senate gone Democrat or the White House gone Democrat and the other houses of Congress stayed Republican. I think they're going to clearly try and take apart Obamacare, and honestly, I do not think the Republican leadership has any idea of exactly how they're going to replace it.
Carmel, you touched on this a little bit already, but one of your main focuses at Keswick is finding a way to help seniors return home after they receive hospital services. How would the repeal of Obamacare affect this, and what could policymakers do to help encourage the practice?
Well, just to build a little bit on something that Peter was saying,
Sure.
I do think the ongoing concern is going to be bending the curve around cost and health outcomes. And that is going to have to be addressed no matter what administration is in place or their tactics for addressing it. And so some of the work around helping to change consumer behavior, physician prescribing practices, and just the overall way our sick care system is set up in terms of how and where we deliver and what we deliver in the form of health care to people. Those changes are going to need to continue to happen. And one of the things that I think about, and I do not think this is likely to occur in our current incoming administration, but I think back to something like, after World War II, when, as a matter of public policy, the GI Bill made it possible for a whole generation to achieve higher education, and the federally backed mortgages with low interest rates and long terms housed an entire generation that would have not otherwise become homeowners. It really is going to take that kind of public policy change to make any real difference. And we don't appear at this point in time to have much of a will for that. So I think in some ways the unraveling of Obamacare is going to be a setback, but eventually we're going to have to come to terms with this. We cannot continue to have this much of our economy consumed by the healthcare sector and have increasingly poor outcomes. And for me, because my focus is on the population that is growing so rapidly and consuming so much healthcare, which is older adults, those issues around, as Peter was saying, capitation and management are going to really have to be a critical part of any kind of program going forward. But I think we're going to see many of the incentives that were put in place for really encouraging people to be more engaged with their own health and have greater access to the supports and services needed to actually impact their own health. I think we are going to see some erosion in that under this new administration.
Barry, under the Obama administration, there have been enormous changes to Medicare physician incentive programs that go into effect in 2019. Could you talk a little bit about these, and are they likely to be kept in place?
They are likely to be kept in place. It comes out of something called MACRA, and it was a bipartisan effort, and it wasn't part of the Affordable Care Act. And basically, starting in 2019, doctors will have 4%, and then over years 5, 6, 7, 8, 9% of what they normally get paid by Medicare withheld from them. And then they can earn back what was withheld, and in fact they can even double it and earn more than what was withheld. And in fact it's a shifting of money from those that don't do well under various criteria, where it's withheld and they don't get it. And the notion is that doctors who begin to use resources well and meet certain quality measures and have electronic medical records and various scores that they do well, they can earn back these amounts. And those are not part of the Affordable Care Act, so they should stay in place. There's an aspect of them that's connected to the Affordable Care Act, or Obamacare, and that is you're actually exempt from these withholds to the extent that you get lots of money through something called advanced alternative payment models. Accountable care organizations are one of those. So if you're active in some of the Obamacare activities, which are nibble at the kind of things that Carmel and Peter were talking about, population health and keeping people healthy, then you are actually exempt from the macro withholds. Obviously, if the Affordable Care Act goes away, the AAPMs go away, and now you're not exempt anymore from MACRA. There's also an aspect of the Affordable Care Act, I hate to keep using all these initials, but it's IPAB, Independent Payment Advisory Board. It was supposed to come online in 2018, and it would allow this independent board to change the way doctors are paid. For example, lower what orthopedic surgeons get, but raise what oncologists are paid. Even the Democrats have been scared of the IPAB, and this group, although it could have already existed, no one's ever been appointed to it. The American Medical Association is greatly opposed to it, and it may never have gotten off the ground anyway. But if the Affordable Care Act goes away, so does this IPAB. But the macro withholds they should survive whatever happens.
Before we continue, a reminder to our listeners, if you have any questions, feel free to submit them, and I'll ask our panelists as we continue. And now, next question for Peter. One of the GOP proposals that has gained some support is called the Patient Freedom Act, first introduced last year by Senator Bill Cassidy, a Louisiana Republican and a physician. The bill proposed that states would distribute funds for their residents to pay premiums through health savings accounts. The bill also would abolish the ACA's requirement that nearly all individuals buy coverage, and that medium-sized and large employers offer health benefits. Is this a viable option to replace Obamacare?
I really don't think so for the majority of people. For people of socioeconomic status that are probably listening to this call, it certainly can be because their companies put in enough in their HSA, or they can contribute enough in their HSA that it'll cover deductibles, et cetera. But with a significant percentage of policies being sold in Maryland and elsewhere being high deductible plans, 5,000, 6,000, 7,000 individually, and double that for couples, rarely are the working class folks going to be able to, those who would have been eligible for subsidies under the exchanges in the Affordable Care Act. I can't imagine that the subsidies will be large enough to help cover those deductibles, and that's going to mean a lot of people going without coverage, which is also going to occur when you don't have the mandates for coverage through the individual mandate. Now, I must say that the qualified health plans, the mandated coverage, is probably too much of a one-size-fits-all in terms of what it has to cover, what a qualified plan has to cover, and that is one of the tweaks or amendments that really should have been made had the Congress not made it so difficult for the President to try and get some of the Obamacare parts fixed up.
Carmel, you have sought out community partners when it comes to some of Keswick's programs. Is this a trend that is likely to continue, or will it be impeded by changes contemplated by the incoming Trump administration?
Well, there aren't that many supports right now for encouraging partnership. Most of what we've seen more recently in Maryland had to do with our Medicare waiver and the incentive for large hospital systems to find ways to better partner with community-based organizations to begin to try to address population health issues and keeping people healthier and in the community and out of high-cost care settings. So there were incentives in Obamacare to sort of encourage that for the hospitals, both through the innovation piece, but also in Maryland because we were able to pursue the waiver that we did. I think that there will continue to be interest in doing this and a great need to do this because there isn't really any way we are going to be able to have any kind of actual impact on the population's overall health, particularly older adults, and their utilization of high-cost settings unless we are networking community-based organizations to engage with those individuals and to support them in those efforts. And it's more cost-effective and more efficient for community-based organizations also to be networked in that way. So it's so hard to know, of course, that's part of what our message is today, how this is all going to play out. But I can't believe that we're going to step away from the overall concern in the country around the cost of health care and the poor outcomes that we are seeing for the health care that we provide. And as that continues, these collaboratives with community-based providers and integrated service networks that include hospital, post-acute care, and community-based care, they're going to be the new design for delivering truly health care instead of sick care. And so I'm not completely discouraged about that. I think it has a sort of inevitability about it, given where we need to finally go. And I also think consumers are going to begin to get more engaged when the real impact of not having health care coverage starts to be felt, particularly by that sort of middle working class group who've had some relief from some of those costs through the Obamacare initiative. So we're going to stay the course with taking this approach of collaboration and these sort of integrated community-based and post-acute care collaboratives and kind of service models, because we think that's probably the most effective way to go about this.
Barry, the President-elect has called for insurers to be allowed to offer policies across state lines, a practice the Obama administration said was not workable. Is this something worth pursuing?
I think the general answer is there's not much here in that statement. That there is something which is close to what Peter was talking about selling products with very low coverage. But let me try to answer it this way. First of all, right now, any of the large health insurance companies can enter any state they want to enter. In other words, the barriers are not that high, and that you can, if you choose, if you want to sell insurance in Maryland, you can come and do it. What's odd is Republicans saying this is an answer at the same time that Aetna is trying to merge with Humana and Cigna is trying to merge with Anthem. And here are the 4 out of the top 5 companies in the country saying they're not big enough. They have to even get bigger. And then this notion that somehow opening up cross borders is going to solve things when even the biggest companies aren't big enough. I think if you allowed a company to sell a South Dakota health insurance product that doesn't cover all of the things a Maryland insurance policy covers, and you allowed people in Maryland to buy a South Dakota insurance policy, which was rather thin, it didn't cover a whole lot, it would be cheaper, and that's true. But that's really about mandates. I'm not sure it's really about opening things up to allow folks to offer products in different states.
Peter, does any alternative to Obamacare need to include some sort of subsidies to help lower income people purchase insurance? Peter, are you there?
The answer is yes. Sorry, I was on mute. And a very simple yes. As we were talking about with the previous question that you asked me and that Barry referred to as well, the cost of health care is obviously very important to many folks, and even $50 to $100 per month expenditure is going to be difficult for lots of people in this country, and that will, without a subsidy to help people afford the premiums, there will be a dramatic increase in the number of people going uninsured again.
And speaking of expenditures, Carmel, the price of prescription drugs, particularly for seniors who tend to need more than other segments of the population, continue to go up. Is there anything the federal government should be doing to deal with the problem of rising prescription drug costs?
Absolutely. And I think it's a complex issue, and I am by no means an expert on pharmacy, but I do know this. it makes no sense to having an older adult who's on some kind of a maintenance drug like a hypertensive medication stop taking their medicine because they can't afford it and have to make choices between the rent or their food or transportation and their medicine. Stop taking their medicine and have a stroke and end up in the hospital and then in a nursing home. So just from the, that's just no sense to approach healthcare in that way. So we know that medication regimes being people following their medication regimes and having access to their medications, both affordability and able to find ways to obtain them, are critical for overall health and controlling the negative outcomes of sort of some of our healthcare policy. I think as long as, but it's not just the availability factor. We really do have a major issue with our prescribing practices, and physicians, I think, need to become better advocates for patient care by being more knowledgeable about appropriate prescribing practices. And we know, some of the opioid epidemic is related to prescribing practices among physicians, which were highly promoted by pharmacy companies. So some of it is prescribing practices, some of it is consumers. Consumers have to patients as consumers have to begin to stop expecting there to be a pill for everything that needs to occur for them to be healthy, because a lot of what needs to occur is really lifestyle changes, and we know that. So my thought is the federal government could be very active in creating incentives that align with the goal of individuals being more conscientious and engaged in their own health and well-being, physicians being better educated and better informed and better about how they prescribe, and then the fact that big pharma has been allowed to really make sometimes just outrageous profits, and that probably is going to have to be reined in some way. This discussion about negotiating with Medicare that I believe our President-to-be brought up during the campaigns, that's an intriguing idea, this idea of being able to negotiate better pricing for Medicare recipients or Medicaid recipients. I think that's an intriguing idea, but I do think there is a role for the federal government in helping to transform our whole relationship with pills as an avenue to health in this country.
Annie, can I chime in for a sec?
Sure, go ahead.
A couple of things. First of all, Medicare being allowed to negotiate as the largest payer of health care in the United States is absolutely critical and should have been done long ago. There's a precedent for it. The VA does so, and the cost to veterans of their prescription drugs is vastly lower. Second, as Carmela was saying, evidence-based practices make great sense. The doc should be following it. Patients should be following it. Simple example, that for non-serious high blood pressure, a simple diuretic at about 1/2 cent a pill works just as well as many of the new generation pills, and that should be in part of practice. And third, the big pharma has made a huge amount of profits on the American taxpayers' backs. The costs of healthcare, of pharmaceuticals sold by American companies in other places in the world cost less in those other countries than here, despite the fact, and what you'll hear is, well, we need to do research and development, it costs a ton of money. Of the 10 biggest, most used drugs in the United States, I believe 8 of them, don't quote me, but I believe 8, are actually developed in universities through grants from the NIH or other federal grants using taxpayer dollars. The licenses are then sold to the corporations, and the big pharma makes the money. So it's a huge issue, It's costing American taxpayers a lot of money, and it's making healthcare costs go up more than they need to.
There were hearings early this year over Mylan Pharmaceuticals and their EpiPen drug. Do you think that the lack of a better term, the sustained outrage there was at the time, can that be continued, or will that just be kind of a flash in the pan, and will people just go back to paying whatever they're being forced to pay for their prescription drugs?
Who are you asking?
Carmel. Peter or Carmel, whoever wants to answer, has any thoughts.
That is part of what I do think we may begin to see, which is some self-advocacy around what it costs to, obtain your medications, and but it isn't simply patients themselves beginning to say, I need this medicine. I should be able to afford this medicine, and therefore there should be some intervention on the part of my government to make that possible. I think it is a combination of, as Peter was saying, using the resources of the government to both fund research and development and then not give it to the big pharma industry, and being able to negotiate for those lower pricing, and for consumers to begin to take some responsibility for this, and in the case where they can use an evidence-based, more appropriate drug, use it. And it would start to, I think, solve some of the issues around these more expensive but life-saving drugs being so costly. It's not going to be one lever we're going to pull, but my hope is, and I experience it when I stand in line at the pharmacy and talk to the people around me, that there is growing frustration around how expensive medicine is and how much it is taking of their either their annual paycheck or their, if they're retired, their retirement resources. And I would hope that can coalesce and be focused toward advocacy in this issue.
Peter, any additional thoughts on that point?
No.
All right.
Thanks.
Barry, many of the GOP proposals include the elimination of mandates that insurers now must provide in their health insurance policies. If this were to happen, how would it affect the overall market?
I think the answer to this one, requires a little digging into the Affordable Care Act. First of all, it not only affects insurers, but also affects self-insured employers. And many people get their health insurance from their employer. If the employer has enough employees, they're actually self-insured, and they're providing care. But the Affordable Care Act affects both of those groups, and it does it in two ways. One, it says to the employers, if you're self-insured, you still have to provide a certain level of care, a level of coverage to your employees. And if you're buying an insured product, the insured product has to have a certain level of mandated coverage. And there are penalties if you don't do that. Well, if the Republicans quickly take away the penalties, employers are then freer to, on a self-insured level, to provide less mandates than they otherwise would be. At least the penalties go away. However, the Affordable Care Act also says, independent of the penalties, employers, you have to do this, and insurers, you have to have these mandated benefits. The Act itself didn't say much. The Act itself said you have to cover preventative care. And then it took years for regulations to come out to say, what is preventative care? So here, and once you take the penalties away, these mandates are still in the law. Perhaps the Democrats can filibuster and keep them in the law. But over time, Congressman Price and others can simply change the regulations It takes time, but they can be changed. So just as the mandates, it took 6 years for them to come forward through regulation, one can imagine them being peeled away also by regulation. If that occurs, then you're back to individual states, which at least mandate what's in insurance policies, but the states do not mandate what's in self-insured plans. So you would imagine that employers would then start, having, not necessarily having lifetime caps could reappear. Mental health parity could go away again. Certain women's care might not be mandated again. Again, the states can protect that on the insured level. The states can't protect that on the self-insured level. So one would think over 6 years we'd peel ourselves back to where we were 6 years ago.
Peter, Republicans have been saying that what they want to provide to Americans is not actual health insurance, but simply access to that insurance. What, in your view, does that mean? Peter, are you there?
Sorry, the mute thing is really getting to me today. Sorry about that. I'm very sorry.
No problem.
I was trying to be quiet for a while Barry and Carmel were talking.
So Republicans are saying that what they want to provide to Americans is not actual health insurance, but simply access to that insurance.
Right.
What does that mean?
So Kevin Brady, who's I believe the chairman of Ways and Means, has said exactly what that means, is that it is literally will be available to all, the insurance coverage, but since folks don't have to get it, it will not necessarily be accessible for all because there may not be subsidies. So in a couple of examples of that, Medicaid expansion is clearly going to go out the door. They are talking about, Congressman Price, who will be the new Secretary of HHS, has talked about block granting Medicaid to the states, which is not a horrible thing to do. However, block grants always come with less money. So although you might say, well, the states should have the right to be able to do what they want with their Medicaid money, that can potentially be true if you have a floor on states like Mississippi and Alabama not going below certain levels of benefits. But when you're going to decrease the payments of Medicaid across the country, that's going to decrease the number of people available for Medicaid. So although one might argue that you have available Medicaid, it's not going to be accessible because there's not going to be funding for it or enough subsidies for it. Similarly, if they do away with the individual mandate tax penalty, that will and subsidies on the exchange, as Barry was saying, you can do that through budget reconciliation. You can't get rid of the exchange with budget reconciliation, but you can get rid of the funding for it, for the subsidies. That's going to make sure you have an available system of getting health care coverage, of going on the exchange, but it is not accessible because you don't have the money to be able to afford to do so, to buy the exchange products with premiums that don't have subsidies attached to them. So they're clearly under what's being proposed now by the Republicans going to be many, many fewer people insured in the relatively near future. The question is how quickly people become uninsured. Will it be in the next year or two when the perception is that Obamacare is being repealed? Or is it going to be over the next 3 or 4 years when this transition ends up leading to some replacement product by the Republicans that will clearly cover less Americans?
You mentioned the block grants that Tom Price has said what he is an advocate for. What are some advantages, if any, of the block grants to the states for Medicare?
Well, I think in a state like Maryland, I mean, as Barry was sort of implying, Maryland is far ahead, along with probably 3 or 4 other states, New York being one of them, California being another, in terms of health care reform on our own. We've already had small group requirements coverage far before the Affordable Care Act. There's bipartisan support, I think. I think Governor Hogan supports much of the Affordable Care Act's mission. Obviously, the congressional delegation does, as does the state legislative delegation. So I think in Maryland, it probably wouldn't make a huge amount of difference because we probably cover what we should be covering, and we probably add funding to help cover some subsidies. However, in other states who would get a block grant that would be less money than they're currently getting, and the ability to say what kind of benefits they want to cover and who they want to cover, that could be a dramatic decrease in people covered, particularly in adults who do not have dependent children, which are a group, a very important group that are a very vulnerable population prior to Medicaid expansion into the Affordable Care Act. In many states like Texas and Florida, they would probably lose coverage. So I think it's block grants in general cannot be terrible, but because the states who don't really want to play well play the game well and won't have the amount of money that they would have otherwise gotten will be detrimental to their population.
Barry, I want to go back to Maryland for a second, and this question may sound familiar because I'm quoting from one of your Daily Record columns. For several years running, Maryland health insurance law was amended to conform with the federal ACA. Some notable changes are a repeal of obsolete pre-existing condition limitations in the group insurance market and the addition of child support or other divorce, legal separation, and death to the list of events that trigger a special enrollment period for small employer health benefit plans. What happens to these state rules if the ACA is repealed?
I think they stay in place. Our history is in Maryland is as we've been innovating, adding mandates and helping folks out, once they're there, they stay. So I don't believe they get pulled back. And as a result of that, it means that insurance may be expensive to buy in Maryland because it has all these bells and whistles. And if there aren't subsidies, it means there will be, again, people who won't be able to afford to buy that which is being offered. But I don't think we have a history of pulling back. In other words, once we make the reform, it seems to stay in place.
Peter, do you see any impacts on Maryland if the ACA is repealed?
I tend to agree with Barry and sort of what I was talking about before in terms of Medicaid. But there certainly are some aspects that will affect us, like perhaps the Center for Innovation won't be funding grants in Maryland and things like that. But I would argue we in Maryland are in better shape than, for example, Texans or Floridians.
Carmel, you have been appointed by Governor Larry Hogan to the state's Commission on Aging. Can you talk a bit about the demographics of the graying of Maryland and how policymakers, either at the state level or the national level, need to respond to these changes?
Well, it's a hot topic, the aging baby boomers. And in Maryland, in less than 15 years, a quarter of our population will be over the age of 60. So that's a significant number of people. It's about 1.6 million Marylanders will be over the age of 60. And there are two parts to the focus both for the Commission and for the Department on Aging and what it means for Marylanders. We know that we want our adult citizens to be able to stay engaged and for all of Maryland to sort of benefit from what we call the longevity bonus, the fact that people are living longer and potentially living healthier and can be really contributing members of our society in so many ways. And so there's this desire to find ways to really engage that, 25% of our population in being a meaningful and purposeful and supportive part of our society. Then there is the issue of, as people grow older, they tend to begin to manifest chronic illnesses, and that what we do see as an ongoing trend and what is such a concern is that people reach their 60s and have maybe 2 chronic illnesses, and by the time they're in their 80s they have 5 chronic illnesses, and they're probably in more advanced stages of those diseases because they've been poorly managed or they weren't prevented to begin with. So we end up having a significant percentage of that quarter of our population who are experiencing disability and unfortunately dislocation, needing to move to a high-cost care setting at some point during these longer years that we're now all living. And the fastest growing portion of the population of older adults in Maryland is the group that's between 80 and 84. And so there is another trend that occurs, which is the older the population, the more we see physical frailty, disability, high utilization of costly health resources, and we also begin to see a greater portion of the population experiencing cognitive issues. So that there's the kind of upside, which is we have this incredible, continuously renewing resource of older adults who, if we manage to find ways to engage them, both in their own health and well-being, but also stay engaged with the larger community, it will be a huge benefit to Maryland. And then the downside is there are these very real issues that occur around frailty and disability that can lead to dislocation that have to be addressed, and there need to be interventions so we can bend the arc of that toward more people staying home and staying healthier. So the Commission on Aging, which is appointed by Governor Hogan, and it's mandated to have both individuals representing the various counties, but also some folks from the government on it. The current commission under Dr. Rosen is focused with the Secretary on Aging, Rona Kramer, on both the involvement of older adults, both as volunteers and as employees and as citizens in the health and well-being of the neighborhoods they reside in, and finding ways to make that happen. But also, back to something Peter said, looking at those existing programs that already are evidence-based, that have research behind them that say, if you do this, you will, in fact, get this better result. And focusing on finding ways of scaling those up and making them more a part of the services and supports that we offer older adults. So I'll give you an example. Hopkins did a tremendous amount of research on a program called Experience Corps, which is aimed at having people over the age of 60 engaged in 15 hours a week of volunteer work in the school system to help children between first and third grade achieve grade level reading. And they researched this, and they found very, very compelling evidence, research findings, that the children did indeed reach grade level reading. And the older adults had these incredible cognitive health benefits, physical health benefits, and reported life satisfaction well beyond people who didn't engage in this volunteer activity. So there's a huge evidence for this intervention for older adults. And so the question is, how do you scale something up like that and make that more available? Because it actually acts almost like an inoculation against many of the negative sort of downward spirals that can occur for people with multiple chronic illnesses who are no longer in the work world, who are becoming socially isolated. This issue of volunteer engagement actually bends the curve in a whole different direction. So that's just one example, and there are many others. So the Commission is interested in supporting our Secretary Kramer in finding ways to get these evidence-based interventions scaled up and more available to the older adult population, with the intent of having those positive impacts.
We only have a couple minutes left. If you have any questions you want to ask our panelists, please ask them now. And my final question to each of the panelists, Barry, we can start with you. Are there any other healthcare issues, either at a local level or state level, that you'll be watching, local, state, or national level, that you'll be watching next year? Anything else we should keep an eye out for?
I have a, sort of a more general comment, which is whatever opinion I offered or any other pundit offers, people have to be careful about. President-elect Trump has proven that pundits are always wrong, and that you can't predict exactly where he'll come out on, drug prices or subsidies or Medicaid expansion. We're predicting what he might do based on what Republicans have said they might do, and that may turn out to be the case. But he might decide to champion one issue or something else and, threaten to give some Republican a nickname, and all of a sudden what we expect to happen, something else will happen. So in some ways, my parting comment is asking, the question is what's health care under the next administration? I think the proper answer is who knows.
Peter, anything you're keeping an eye out on in particular going forward?
I don't disagree with Barry. Clearly, it's there's a lot of whims it's a kind of a whimsical, that's a nice way of putting it, the way that the president-elect has been looking at things. I think, though, that unless we start really dramatically reining in the cost curve and making sure we get the best care available, we're going to end up down the road with a single-payer system, which I must say I've always been in favor of. I'm actually more in favor of it now, having run an insurance company. There's so much money that is wasted on administrative costs and redundant middlemen and middlewomen kind of projects that I think we'll end up with a single payer potentially sooner rather than later. I just don't think the government should run it. They should subsidize it.
And Carmel, anything you're looking out for?
I think I'm kind of focused on Maryland right now and looking at what is likely to continue with our redesign of the way we're delivering our healthcare services and our focus on, controlling our cost and getting better health outcomes for folks. And I think that in many ways, the train has left the station on all of that. And although we don't know and we can't know for sure how that's going to all play out specifically, I do think that we will continue to see movement in that direction. And like Peter said, whether it's a single-payer system or some other design change, I believe that's inevitable. So I'm looking for those incremental sort of changes that are happening that are sort of continuing in that direction as we go forward.
And with that, we're going to wrap up today's webinar. And I'd like to thank our panelists once again, Dr. Peter Beilenson, President and CEO of Evergreen Health, Carmel Roques, CEO of Keswick, and Barry Rosen, Chairman and CEO of Gordon Feinblatt, LLC. We will keep today's session on our website if you want to watch or hear it again. You can also go to thedailyrecord.com to read today's legal and business news. And as a thank you for joining us, we're offering our audience a 1-year digital access to the Daily Record for only $99, or $70 off the regular subscription price. You'll find the promo code in the email we sent you prior to the webinar, and in a follow-up email you will receive this afternoon. Thanks again to all who joined us this afternoon. Happy holidays and Happy New Year.
Thank you.
Bye, everybody.
Bye.